Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, listeners. It's Lindsay Smith-Rogers. Dr. Walter Orenstein is one of the nation's foremost experts on vaccines. An emeritus professor at Emory University and the former director of the Immunization program at the Centers for Disease Control and Prevention, he joins Dr. Josh Sharfstein to talk about the vaccine schedule, its origins, how it once was put together, and what he thinks about recent events. Let's listen.
Dr. Walter Orenstein, it is fantastic to have you here on Public Health on Call. How are you doing today?
Doing okay, although concerned about potential resurgences of vaccine-preventable diseases given our current situation.
Well, we're going to talk about that in a minute. But first, I want our audience to meet you. I know of you as someone who has had one of the most distinguished careers related to vaccines and vaccination in this country.
Yes, I really got involved with vaccines when I came to CDC in 1974, went to India and worked on eradicating smallpox, trained in infectious diseases, came back to CDC in the immunization program. I was there for 26 years total, including 16 that I was director of the U.S. immunization program, and have since continued to work in vaccines and vaccine-preventable diseases at Emory and at the Gates Foundation.
Smallpox was quite a disease, totally wiped out by vaccination. Could you just tell me a little bit about your experience there? What was the smallpox epidemic like?
The smallpox was a terrible disease. That was variola major, which is the name of the virus, and it killed roughly 30% of the people who got infected. When I went to India, I could see all these people with pock marks because those who survived often were left with scars. The smallpox vaccine was highly effective. The issue was to get people who needed it vaccinated. My favorite line is vaccines don't save lives. Vaccinations save lives. A vaccine dose that remains in the vial is 0% effective. And so a big focus in smallpox was to get vaccinated the people who were exposed or could be exposed and break the chains of human-to-human transmission. And because the smallpox virus required transmission, by breaking those chains, we could protect even unvaccinated people, which we've done. And we stopped vaccination because we no longer need it. Smallpox virus is not around.
Would it be an exaggeration to say that eradicating smallpox through vaccination has saved millions of lives?
Millions of lives, and it also has had substantial economic benefits in terms of reducing healthcare costs and indirect costs so people can work and their lives are not disrupted.
So you have this incredible experience helping the world eradicate smallpox. You come back to CDC and you get involved in the National Vaccine Program. Tell me a little bit about how that program started.
Yes, the National Vaccine Program was started actually when President John F. Kennedy signed the Vaccination Assistance Act in 1962. This led to a grant program to states, often called the 317 Grant Program, where the CDC would give grants to states to help them in implementing vaccination policies. So the 317 Grant Program has played a big role in reducing vaccine-preventable diseases and got rid of polio. We haven't had a polio outbreak in the United States since 1979.
So beyond the 317 grant program you're talking about, the federal government began developing a vaccine schedule. Tell me about the origins of that.
The vaccine schedule was developed by a committee called the Advisory Committee on Immunization Practices, which was established in 1964. It was a committee of experts in vaccines, in public health, in clinical medicine, and it had advisors such as pediatricians, public health practitioners, etc., in developing its recommendations. There were, for a period of time, differences in recommendations between groups like the ACIP and the American Academy of Pediatrics, but they were not major differences. And then in 1994, we developed a consolidated immunization schedule that all of the major groups, such as the American Academy of Pediatrics, the American Academy of Family Physicians, the CDC, and others, and that, until very recently, was a single standard schedule for children and adolescents and a standard schedule for adults. That has changed this year because of major changes from the government now that have, in my time, had never been made before, with the Department of Health and Human Services developing a schedule without the usual ACIP discussions and recommendations.
We'll get to that for sure, but let me just ask you, why have a schedule? Why aim for a single recommended set of vaccinations?
I think the point is it makes it easier for persons who take care of individuals to determine what to give for vaccinations or what not to give. And then it also helped in getting us two presidential initiatives on immunization. One was in the Carter administration with a focus on supporting immunization mandates because of the benefits not only to the vaccinees but the community. And the other was in the Clinton administration in the 1990s, where the schedule became a way of ending financial barriers to immunization by creating something called the Vaccines for Children program, which now covers the vaccine costs for about 50% of children in the United States.
So this schedule provided a clear message about which vaccines were recommended at different ages where the benefits would exceed the risks. And a lot was riding on it. As you said, for some of these vaccines, states might set requirements for school entry. And for these vaccines, there would be funding so that people could actually have access. So it's a pretty big decision how to shape the schedule. What was that process like?
The first priority is that you have an approved vaccine by the Food and Drug Administration. Once the vaccine is approved, then committees like the ACIP look at what the benefits of vaccine are, what the risks of vaccine are, whether there are subpopulations that get greater benefit than others to limit the recommendation to a subpopulation versus a universal vaccination, and then look at implementation. What is a reasonable way to implement it? The ACIP more recently had developed and used a very great process to develop its recommendations. It started with something called PICO, P-I-C-O. That is, P is the problem. What is the issue? What is the disease that needs to be prevented? I is what is the intervention? Is it a vaccine? Is it immune globulin, etc.? C, what is the comparison? For example, a placebo, the already existing vaccine. How do we compare the two? And O is looking at what the observational studies are in terms of how effective the vaccine was. And so they would look at very carefully what is the problem, what are the benefits and harms, what are the values in that, how acceptable would it be to providers, to people for whom it would be recommended, how much will it cost to implement, including the vaccine cost and the implementation cost, and how feasible is implementation, and it will all be considered. And what the ACIP would do is have working groups which consisted of ACIP members. It consisted of external liaisons, such as American Academy of Pediatrics representatives and others, and go through this very detailed process before it's brought in public to the overall committee to make a recommendation. That has changed this year, but up until that point, that was the process.
Let me ask you about balancing benefits and risks of vaccines. Sometimes you'll hear somebody talking about how great a vaccine is, the disease that it prevents, and other times you hear someone, worried about a particular side effect. How does a committee like the Advisory Committee on Immunization Practices, at least when you were familiar with it, how does it try to balance the benefits and the risks?
Well, what's looked at is, again, what is the problem if we fail to vaccinate? What is the cost? What are the complications? How many deaths are there? How many hospitalizations are there? And then comparing it with what are the risks of death, the risks of serious side effects, the costs of this, and the cost of actual vaccination, and what the cost-benefit ratio is. And this also gives a time the recommendations are discussed in public. The public has an opportunity to comment. So, for example, the ACIP for many years recommended the oral polio vaccine developed by Albert Sabin initially. It prevented outbreaks, but it caused about 8 to 10 people in the country to be paralyzed, called vaccine-associated paralytic polio. And the ACIP reviewed this issue, and people with paralytic polio caused by this came to the ACIP meeting in 1996, and we switched to the inactivated, the Salk vaccine, to protect them at a cost of $3 million per case of vaccine-associated paralytic polio prevented, because the Salk vaccine was much more expensive. But the ACIP does that and can evaluate values, both numeric values and ethical values.
Now, you mentioned that things have changed lately. I just wonder what it's like for you knowing this huge process that is put together, the thorough review of data, the consideration, the public meetings, to read in the paper that you wake up one morning and they've just changed the immunization schedule with the stroke of a pen.
I am very concerned because I think, one, the recommendations should be made in public with an opportunity for people who oppose the recommendation to contribute to the discussion and to have experts from various groups comment. I cannot remember when an immunization schedule in my career was developed at the Health and Human Services level without the ACIP or these other organizations participating in it. And so I'm very concerned. And it could be that we accept that schedule, but it's important that people have an opportunity to evaluate it in a traditional manner in terms of balancing benefits and risks and using the PICO format and what's called the evidence to recommendations process, which was previously used by the ACIP, which put out in public the ability to understand what went into the recommendation, why it was made, and giving people more confidence in that recommendation so they were better able to implement it.
Is the failure to follow this kind of process what is making you nervous about the resurgence of vaccine preventable diseases, which is where this podcast started?
I am very worried. I would hate to see a polio outbreak. I've seen polio cases. I would hate to see a return of meningitis. Trained in pediatrics in the 1970s and prided myself as being really good at doing spinal taps, lumbar punctures to diagnose meningitis. Now, because we have great vaccines against Hib, against meningococcal disease, pediatricians say, I've never seen a case of meningitis. I would hate that to have to come back. And I'm concerned about the hesitancy. And I think the need to educate people that we have a complex process before we approve a vaccine. And I use as an example the human immunodeficiency virus. The human immunodeficiency virus was discovered to be the cause of AIDS more than 40 years ago. We had promising candidates, but none of them met criteria for safety and effectiveness to get approved.
I'm going to ask you this one final question. You were in charge of the CDC's vaccine program. You have worked decades on vaccines. If someone were to bump into you in the street and say, what is a vaccine? What does it do? How would you answer that question?
The way I try to explain vaccines is I start with the immune system. The immune system functions like an army or police force. Its goal is to detect the invader and destroy it before that invader does damage. You would never send an army into battle without practice, without training. What a vaccine does is it gives the immune system practice so that it can recognize the invader rapidly and destroy it before that invader can do damage. And there are different ways, there are different kinds of vaccines, but all of them induce this immune response in the vast majority of vaccinees, and it protects not only that vaccinee, but it protects the community, including people who can't be vaccinated, people who have compromised immune systems and can't make protective immune responses.
Dr. Walter Orenstein, thank you so much for joining me on Public Health On Call.
Thank you very much, and thank you for educating people about the importance of vaccines and vaccination.
Public Health On Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Rachel Walsh. Audio production by Michael Bonfils, Matthew Martin, and Philip Porter, with support from J.B. Arbogast, Spencer Greer, and Chip Hickey. Distribution and social media by Rachel Walsh, with support from Nick Moran and Brianna Iacovelli. Follow us on Instagram and Blue Sky at Public Health Pod for more public health takes and special content. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.